This man, like millions of others on this particular day, is walking to work, to a bus stop, a parking lot, to a store, or is on his way home. But he will never reach his destination. He is about to suffer a cardiac arrest, a heart attack. If he is lucky, and if someone is nearby, emergency medical help will be summoned. That same bystander, if knowledgeable in cardiopulmonary resuscitation, will immediately begin basic life support. If unlucky, he may die alone on the street. There is no pulse, no breathing. Do you wring your hands in helplessness and perhaps watch the cardiac arrest victim die within minutes? Or begin immediate CPR and possibly save that life? Cardiopulmonary resuscitation, CPR. Each year, basic life support saves the lives of thousands, men, women, children, and infants, victims of heart attacks, traffic accidents, drowning, choking, suffocation, electrocution, drug overdose, strokes, criminal violence, all types of traumas in which the victim is without a pulse and breathing. When the cardiac arrest victim is without professional medical help, there is absolutely no substitute for basic life support. In 1986, some 40 million Americans reportedly knew CPR, 150 million worldwide. But those totals aren't good enough. 100% of our able-bodied population over the age of 10 should know basic life support. 190 million Americans should be knowledgeable. This video cassette offers very important basic life support information, and we urge you to pay close attention. The knowledge you gain may mean you might one day be able to save a life, perhaps the life of a loved one. But CPR, the way to save lives, is not the total answer. As thorough and authoritative as this video cassette is, there is no substitute for an individual's being taught basic life support by a certified instructor and mannequins, similar to those you will be seeing, being used in a hands-on class. The application of CPR is totally positive in a totally negative life-threatening situation. A heart attack, any trauma responsible for the victim's being without a pulse and breathing, is negative. The victim is dying. Yet CPR can totally change the trauma. CPR's combination of rescue breathing and chest compressions is designed to keep oxygenated blood flowing to the lungs, brain, and other organs. When a rescuer, you perhaps, realizes CPR is necessary, it should be started immediately, now. There should be absolutely no hesitation. Seconds are vital. None should be wasted. The cardiac arrest victim on whom CPR is started immediately has nearly 3 times the chance of being resuscitated as does the victim on whom basic life support is delayed as little as 4 minutes. This point cannot be overly stressed. When a victim is in a life-threatening situation and basic life support is necessary, the rescuer should begin it immediately. Immediately. The instant breathing and pulse stop, the victim is clinically dead. Resuscitation is possible. However, biological death can begin as little as 4 minutes later. Biological death means the brain is being deprived of oxygenated blood and is dying. Even though resuscitation might be possible, the victim could have some degree of irreversible brain damage. The heart attack statistics are grim in the United States. As many as 1.5 million Americans may have heart attacks this year. While we're often aware of the victim being stricken while shoveling snow, jogging, or doing something else physical, a high percentage of heart attacks occur while the individual is at rest, eating, reading, watching television, or sleeping. About 550,000 of the victims will die. Sudden death from heart disease is the major medical emergency in the United States today. Approximately 360,000 deaths, 65% of the fatalities, will occur outside of hospitals and usually within the first 2 hours after the onset of symptoms. Yet, prompt implementation of CPR can and does save lives. The positive news is that some 900,000 of the 1.5 million stricken will eventually return to productive lives. The common symptoms of a heart attack: uncomfortable pressure or fullness, often severe pain in the center of the chest. Pain lasting 2 minutes or longer may spread to the neck, shoulders, or arms. Pain may be accompanied by a cold sweat, nausea, dizziness, and shortness of breath. Fainting is a possibility. But often there are only 1 or 2 symptoms, sometimes no symptoms. The conscious victim will very often deny having a heart attack, blaming indigestion. Do not accept the denial. Have the individual sit down or lie down. Immediately phone 911 or a 7-digit emergency number. Answer the dispatcher's questions quickly and clearly. Let the dispatcher hang up first. 911 may be reached without coins from most pay phones. If there is transportation but no organized emergency medical service available, the suspected heart attack victim should be transported to an emergency medical facility. But the trip should only be started if the victim is conscious and if a second person will accompany the driver. If either knows basic life support, so much the better. The unresponsive victim, no pulse and no breathing, should not be moved. CPR should be started immediately. The rescuer in this important sequence is paramedic Glenn Sinks of St. Louis County, Missouri. He is a longtime volunteer CPR instructor trainer with the St. Louis chapter of the American Heart Association. The rescuer must first determine that the victim is a victim. The rescuer's voice is a great ally. Whatever the trauma and wherever the victim may be, the rescuer should always shout for help. Effective CPR requires speed and thoroughness. But for the next few minutes, in order that the viewer understand all procedures, Glenn will perform them slowly and deliberately. Since CPR can only be performed with the victim face up and fully prone, Glenn will demonstrate the turning maneuver again. Notice the care he exercises. If the face-down victim's legs are drawn up, they should be straightened. The furthest leg is then placed over the nearest leg. This move brings the lower body weight to the rescuer. The arm nearest the rescuer being raised above the victim's head will also make the turning easier. Glenn's upper hand is placed behind the head and neck of the victim, his lower hand going under the furthest arm to brace the torso and shoulder. Note how the body is being turned as a unit, the head and neck being protected against excessive movement in case there is a neck or spine injury. As soon as the victim is face up, the arm over the head is placed along the side. Glenn is now ready to initiate the A in the ABCs of CPR. He will open the airway. Glenn knows he has a victim, but doesn't know if the victim is in full cardiac arrest, no pulse, no breathing, or in respiratory arrest, having a pulse, but breathless. He will have his answer shortly. The airway is opened with the head tilt, chin lift maneuver. The heel of Glenn's upper hand on the forehead, the fingers of the lower hand on the jawbone directly under the chin. The head moves back from the slight pressure on the forehead and the chin being lifted. Let's see the procedure again. There is no question that the head tilt, chin lift maneuver is best for the non-medical person to use and best for the victim. Since the head's being tipped and the chin lifted raises the back of the tongue from the opening of the windpipe, it's possible the victim may begin spontaneous breathing. The head itself should never be lifted from its firm surface, since that could complicate the unblocking of the windpipe. Neither should the head ever rest on a pillow or on any other type of elevation, since that could further complicate an obstructed airway. As soon as the airway has been opened, the rescuer will immediately check for breathing. Glenn's ear is close to the victim's mouth, his eyes focused on the upper chest. This is a three-way breathing check. He hopes to hear the sound of breathing, to feel warm air on his cheek, and to see chest movement. This check for breathing is vital and should take 3 to 5 seconds, never less than 3 seconds. Less than 3 seconds, and the breathing could be missed. Let's see the breathing check again. Notice that Glenn maintains the open airway, his hands in their proper places. If there is breathing, no matter how shallow, that means there is a pulse as well, and CPR isn't necessary. Repeating, if there is breathing, there must be a pulse. However, there can be a pulse and no breathing. This would be respiratory arrest. Glenn is about to initiate the B of the ABCs of CPR, breathing. He has determined the victim isn't breathing and will ventilate twice. Each inhalation should take 1 to 1.5 seconds, with at least a 2-second pause in between the breaths. Before beginning ventilations, Glenn will pinch the nostrils closed with the thumb and forefinger of his upper hand, but will continue to maintain the head tilt. Note his upper hand. He also makes a firm seal with his mouth around the perimeter of the victim's mouth. As he ventilates, his eye focuses on the chest since he's looking for movement. Each breath is a fresh breath, an individual breath. Glenn demonstrates again. If the nose seal isn't firm, the ventilations will be wasted, the air escaping through the nostrils. If the mouth seal isn't firm, here too the ventilations will be wasted. While there can be perfect nose and mouth seals, if the airway isn't fully open because of improper head tilt, the important ventilations won't reach the lungs. Glenn shows how far back the victim's head should be tipped. Circulation is the C in the ABCs of CPR. Is there a heartbeat, a pulse? Glenn will find out by checking the carotid artery nearest him. Chest compression should never be started until a pulse check has been made, and the lack of a pulse says compressions are necessary. The carotid arteries, and there are 2, are on either side of the windpipe, between it and the neck's strap muscles. Why check the carotid pulse and not another pulse? First, the rescuer, having just completed ventilations, is in the immediate area. But more important, the carotid arteries are closer to the heart than other pulses. The carotid arteries may continue to function when all other arteries have stopped. Their pulsation is absolute assurance the heart is beating. Lack of a carotid pulse tells the rescuer chest compressions are needed. Let's see the carotid pulse check again. Notice that the forefinger and middle finger are placed in the hollow of the throat, then slid into the groove between the windpipe and the muscles at the side of the neck. The carotid pulse check lasts from 5 to 10 seconds. A check of less than 5 seconds could mean a weak pulse might be missed. A pulse should never be checked for less than 5 seconds. True seconds are counted as Glenn is counting them.
2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6, 1,000, 7, 1,000, 8, 1,000, 9, 1,000, 10, 1,000.
Each step in basic life support, whether for an adult, a child, or an infant, determines if a following step is necessary.
Are you okay?
Glenn determined he had a
Somebody
victim
get some
before
help.
shouting for help. He opened the airway and checked for breathing. Since there was no breathing, he ventilated twice. He then checked the carotid pulse. No pulse, and he knew he had to begin chest compressions. Adult compression should be 1.5 to 2 inches. Compressions of less than 1.5 inches will be ineffective. Each compression pushes blood through the heart to the lungs, brain, and elsewhere. When the chest rises, the heart fills with blood. 4 sequences of 15 compressions and 2 ventilations each will mean the rescuer will have completed about 1 minute of CPR. A basic life support minute is considered to be from 52 to 73 seconds. Compressions can generally be more effective if the rescuer's hands are on the bare chest. As quickly as possible, outer garments should be unbuttoned, unhooked, unsnapped, unzipped, or ripped open. Undergarments should be pushed up. Speed is essential. Here we're talking of less than 10 seconds. In basic life support, the rescuer's hands are never referred to as the right hand or the left hand. The hands are always the upper hand and the lower hand. Note the rib margins, specifically the rib margin nearest the rescuer. Also note the xiphoid process, a small piece of cartilage often referred to as the notch, attached to the bottom of the sternum or breastbone. If the rescuer were standing over the chest, straddling it, he might picture the rib margins as a church steeple, the notch at the apex or peak. The notch is the rescuer's landmark, the home base from which each sequence of 15 compressions begins. Note that Glenn is kneeling directly over the chest, his thighs against the arm. Even though it is essential that the rescuer's hands be properly placed over the heart for the compression to be effective, Glenn's initial movement is to the bottom of the rib margin. A rescuer never reaches across the diaphragm to the opposite rib margin. The fingers are then moved up the rib cage to the notch, the middle finger resting lightly on it. The index finger touches the middle finger, both fingers straight. Glenn now places his upper hand next to the index finger of the lower hand. Specifically, the heel of the upper hand is adjacent to the finger on the breastbone directly over the heart. It is only now the landmark location, the middle finger of the lower hand being on the notch, is left. Glenn places his lower hand directly on the upper hand, the hands never being crossed, then extends or interlaces the fingers. He is about to begin his compressions, but will first be sure his shoulders are directly over the breastbone, elbows locked, his back and arms straight. Glenn can now be sure his compressions will be straight down, not made at an angle. The compression depth of 1.5 to 2 inches can be realized almost exactly if the rescuer visualizes 2 inches on a ruler. After each compression, when the chest rises, the hands do not leave the chest. Light contact is always maintained. Otherwise, each time the hands return to the chest, they would bounce. Not only would the compressions be wasted, but injury could result. Glenn demonstrates the light contact of each compression. It's absolutely essential the rescuer return to the landmark position, the notch, before beginning each 15 compressions. Failure to begin compressions properly could result in the compressions being made on the notch. It could then break off and possibly lacerate the spleen and other organs. Yet, even if compressions are done perfectly, there is always a chance of rib injury. However, compression should never be stopped for reasons of any suspected injury, since the alternative to no compressions is death. Glenn will now do 15 compressions in the time frame in which they should be done, 9 to 11 seconds.
4 up, 5 up, 1 up, 2 up, 3 up, 4 up, 10 up, 1 up, 2 up, 3 up, 4 up, 15.
3 important points. If you, the rescuer, believe resuscitation is possible, never allow a non-medical individual to discourage you from starting or continuing basic life support. Don't worry about being sued if your CPR attempts don't resuscitate a victim. No successful legal action has ever been brought against an individual who gave CPR in good faith. Point 3. Never give up on resuscitation attempts on a drowning victim, even if you know the individual has been under the water 20 minutes, 30 minutes, or longer. Since the body's system slows down dramatically underwater, the brain not requiring as much oxygenated blood, do not give up. That extra minute you give may make the difference.
Are you okay? Are you okay? Somebody get some help.
Glenn will now demonstrate a basic life support minute. The minute, 52 to 73 seconds, begins with the first compression and ends with the last ventilation, a total of 60 compressions and 8 ventilations.
1 up, 2 up, 3 up, 4 up, 5 up, 1 up, 2 up, 3 up, 4 up, 10 up, 2 up, 3 up, 4 up, 15. 1 up, 2 up, 3 up, 4 up, 5 up, 1 up, 2 up, 3 up, 4 up, 10 up, 1 up, 2 up, 3 up, 4 up, 15. 1 up, 2 up, 3 up, 4 up, 5 up, 1 up, 2 up, 3 up, 4 up, 10 up, 1 up, 2 up, 3 up, 4 up, 15. 1 up, 2 up, 3 up, 4 up, 5 up, 1 up, 2 up, 3 up, 4 up, 10 up.
CPR is so vital that a rescuer should do the minute before making the emergency phone call, even if the phone is within a few feet. The minute is up.
1003, 1004, 1005.
The unchangeable basic life support rule is this: never interrupt CPR for more than 5 seconds, unless for a very significant reason, and then for only a few more seconds beyond the 5 seconds. A phone a block away is a block too far away. Unless there is a specific law that states otherwise where you live, no non-medical person is legally obligated to attempt basic life support on another. There may be a moral obligation, but that rests with the individual. However, once a non-medical person begins CPR, he or she is expected to continue it until the victim is resuscitated, a life support team takes control, another person knowledgeable in CPR takes over at the rescuer's request, a medical doctor or physician-directed team takes over, or the rescuer is unable to continue. If the cardiac arrest victim has dentures, unless they begin moving, they should be kept in place, since they will help form a foundation during ventilations. A pacemaker implanted in the victim's chest should present no problem. If it's functioning, just to be sure, the rescuer should check for a pulse. If it isn't functioning and there is no pulse, compressions are needed. Although chest compressions might cause some rib injury, the rescuer should never stop compressions, since the alternative to injury could be death. Prudent heart living includes no tobacco in any form, maintain proper weight, exercise regularly, eat properly, control high blood pressure, and only moderate alcohol consumption. Health-wise, we all have specific risk factors. Some we can control, others we can't. If coronary heart disease was prevalent in past generations in a family, it's likely that present and future generations will be similarly affected. Women have fewer coronary problems than men. Black Americans have about a 45% higher chance of being high blood pressure victims than do white males and females. 37 million American adults have diagnosed high blood pressure. If left untreated, hypertension can lead to heart attacks, kidney failure, and strokes. Coronary heart disease problems increase with age. Don't smoke, chew, or use smokeless tobacco. Have frequent blood pressure checks. Having a sensible diet will help control cholesterol. Here too a physician should be consulted. Diabetes can be controlled. Contributing risk factors that can be changed in our lives include stress, too much weight, and too little exercise. Unlike the adult victim who needs CPR because of cardiac arrest followed by respiratory arrest, children and infants rarely suffer cardiac arrest from cardiac causes. Most generally, children and infants will first suffer respiratory arrest, no breathing, followed by the shutting down of the heart's function. The child or infant with no breathing and no pulse is in full cardiopulmonary arrest. These life-threatening traumas occur because of traffic accidents, fires, drowning, obstructed airways, poisoning, and other types of accidents. The child in respiratory arrest may have less than 2 minutes after breathing stops until the heart quits functioning. The rescuer then should begin the basic life support without hesitation, first determining the child's unresponsiveness. Although CPR, whether on an adult, a child, or an infant, has many similarities, there are major differences, and the rescuer should be aware of them. First, for the purposes of CPR, a child is considered to be a boy or girl between the ages of 1 and 8 years. Pediatricians say the average boy or girl of 8 weighs between 50 and 65 pounds, girls generally being slightly heavier than boys. Rescuers must use common sense, and if there is a doubt whether the victim is older than 8, he or she should be given adult CPR. Janet, a registered nurse, is the wife of Glenn Sinks.
Hey, boy, can you speak? Can you hear me?
Not getting any response, she will immediately shout for help.
Somebody get some help.
Janet raises the arm nearest her over the child's head. This move will help make the turning easier. She then places her upper hand in the back of the head and neck, in case there is a neck or spinal injury. Her lower hand goes under the arm furthest from her, neutralizing the shoulder and torso. The body is then turned as a unit. As soon as the child has been properly positioned, Janet will lower the raised arm to the victim's side. The airway is open the same as an adult's, Janet's upper hand going to the forehead, the fingers of her lower hand under the chin, directly on the jawbone. The head is tipped back, the airway opened with slight pressure on the forehead. While maintaining the open airway, Janet will now check for breathing. Her ear is close to the victim's mouth. She hopes to hear the sound of breathing and feel the air on her cheek. Her eyes are focused on the chest because she's looking for movement. This breathing check is made for 3 to 5 seconds, never less than 3 seconds. She quickly seals the nostrils with the thumb and forefinger of her upper hand. This firm seal will prevent air escaping when she is ventilating. She now places her mouth around the perimeter of the child's mouth and breathes slowly outward. Her eyes are on the chest because she wants to see it rise when the air enters the lungs. Janet now ventilates twice, each inhalation lasting 1 to 1.5 seconds, with a brief pause in between the breaths to allow the chest to relax. Janet next checks the carotid pulse, the neck artery nearest her. In adult and child CPR, rescuers should always check the carotid artery, since it is the artery nearest the heart and often will be functioning when other arteries have stopped. The similarity in child basic life support with adult CPR continues when Janet locates the landmark, the notch attached to the bottom of the breastbone. The middle finger of her lower hand rests on the notch. She now places the heel of her upper hand directly next to the index finger of her lower hand and in the middle of the breastbone. Her compressions will be done with that upper hand. Her elbow is locked, her arm straight. Her 5 compressions will be done in 3 to 4 seconds, each compression 1 to 1.5 inches deep. As a rescuer, Janet would do 1 minute of CPR before making her emergency phone call, if the call could be made in no more than 10 to 12 seconds. Although she initially ventilated twice, as she begins her basic life support minute, Janet will ventilate only once for each 5 compressions. Each time she ventilates, her eyes will remain focused on the chest. Janet's CPR minute, 10 cycles of 5 compressions and 1 slow ventilation each, will run from 60 to 87 seconds. Here is that basic life support minute. Infant CPR for girls and boys of 1 year and younger can be given with the victim on the ground, a floor surface, a bench, coffee table, or conventional table. If the infant is on a table, the rescuer could possibly be seated and have more control, or could lean over the victim and be more comfortable. However, a rescuer should never delay starting infant CPR by looking for a table and chair. Infant basic life support, like child and adult CPR, should be begun as quickly as possible, with the rescuer adjusting to the situation and surroundings. If a table is used, extreme care must be taken by the rescuer that the head isn't hyperextended, perhaps by being too far over the edge of the table. Note that the airway is opened with the head tilt chin lift maneuver. Then the three-way breathing check is made for 3 to 5 seconds. In infant CPR, when ventilations are necessary, the rescuer does not seal the nostrils with 2 fingers. Instead, Janet seals the victim's nostrils and mouth with her mouth. 2 ventilations are then made, each taking 1 to 1.5 seconds with no pause in between. Janet's eyes remain focused on the chest, seeing it rise but also seeing it deflate. Immediately after the ventilations have been made, the brachial pulse is checked on the inside of the upper arm between the elbow and shoulder. This pulse is the easiest to check on an infant. However, the rescuer should be certain the check is made with the tips of the 2 fingers only. The thumb, because it has its own pulse, must be kept off the arm. Since there is no pulse, chest compressions are necessary. These compressions are made with the tips of 2 fingers of the lower hand, placed vertically on the breastbone, a finger's width below an imaginary line between the nipples. Janet demonstrates the finger's placement again. The compressions are made at a depth of 1/2 to 1 inch. 5 compressions are given in 3 seconds or less, the fingers remaining on the breastbone on each upstroke. After 5 compressions, Janet will slowly ventilate once. Janet demonstrates the entire sequence again. She opens the airway and checks for breathing. She then gives 2 ventilations. The brachial pulse check follows. The landmark is located and compressions made. Janet will now demonstrate 10 cycles of 5 compressions and 1 ventilation each in 45 seconds or less. After completing her 10 cycles, Janet will check the brachial pulse for 5 seconds, and if there is no pulse, she will ventilate once, then begin another 10 cycles. This procedure would be continued until the infant is resuscitated or emergency medical help arrives. This year, as in previous years, more than 3,000 obstructed airway fatalities will occur in the United States. Not reported will be the hundreds of thousands of near misses or close calls. In this sequence, Marcia Pete of Memphis, Tennessee, is doing a series of Heimlich maneuvers on Kathy Johnson, a registered nurse also of Memphis. The Heimlich maneuver is also known as an abdominal thrust. Most adults and children choke on food. If the obstruction isn't immediately relieved, the victim could be dead in as little as 2 minutes. However, the choking victim who becomes a National Safety Council statistic doesn't choke to death, but suffocates. The hands at the throat are generally considered to be the universal distress signal for an obstructed airway, but a rescuer shouldn't wait for that move because it may never come. The face and eyes will tell the story. The eyes may be shut tight, or they may be wide open, showing terror. A bluish tint may show on the face, spreading into the lips and toward the base of the fingernails. The rescuer may hear an ineffective cough or a high-pitched and very scary sound while the victim is trying to inhale. But then again, the victim could be totally quiet. One of the most important points to know in obstructed airway is that choking is always serious, and the victim with an obstructed airway should never be left alone. Kathy will now demonstrate the exact moves a rescuer should make. She approaches Marcia, quite certain she is a choking victim.
Are you all right? It's going to be okay. I'm going to help you. Can you cough for me? Cough! Cough! I need some help, somebody.
Since there has been no response from Marcia, Kathy knows she has to take prompt action. Quickly, she steps behind her, grasps her around the waist, and begins a series of Heimlich maneuvers. These abdominal thrusts are given one after another until the obstruction is expelled or the victim becomes unconscious. Now we'll see the sequence done slowly. With the fingers of her left hand, Kathy locates the navel. She holds the position. She then makes a fist of her right hand, tucking the thumb inside, and places the fist, thumb side in, against the abdomen, directly above the navel. The lower hand is then moved and grips the fist. Under no circumstances should a rescuer ever put a finger into a conscious victim's mouth and attempt to remove the obstruction. Serious injury could result to the rescuer. Once again, these maneuvers are continued until the obstruction is expelled or the victim becomes unconscious. If unconsciousness does result, the victim should be aided to the floor or ground and placed face up, legs straight, arms at the sides. Saving lives isn't restricted to adults. Although he has never taken a basic life support class, Brian is familiar with the Heimlich maneuver and knows a choking victim when he sees one. In this sequence, Glenn, well over 6 feet and more than 200 pounds, is the victim of an obstructed airway. If the conscious choking victim becomes unconscious, and if no one had responded to the rescuer's first shout for help, another shout should be made.
Help! Somebody help!
Marcia now uses the tongue-jaw lift to open the mouth, peers inside, and if the foreign object were visible, she would pluck it out or sweep it out with one finger, sweeping it along the inside of the cheek. Let's see the tongue-jaw lift demonstrated again. The lower hand is always used, the fingers on the jaw directly under the chin, while the thumb presses on the tongue. This maneuver will give the rescuer an unrestricted view. If the obstruction is visible but can't be removed, it's possible it can be pushed to one side. This would give the victim a partial airway opening. But in this sequence, we're saying the foreign object isn't visible, and Marcia will now open the airway exactly as Glenn and Janet did with their victims, using the head tilt chin lift maneuver. The upper hand on the forehead pushes the head back. The fingers of the lower hand lift the chin. She next seals the nostrils with the index finger and thumb of her upper hand, inhales deeply, and attempts to ventilate. Marcia didn't take the time to check for breathing because she already knew the victim wasn't breathing. Because the airway continues to be obstructed, the ventilation attempt is unsuccessful, and Marcia immediately straddles the victim's thighs and begins a series of up to 10 Heimlich maneuvers. The thrusts are made with the heel of the lower hand. Although there could be up to 10 thrusts delivered in a sequence, if the obstruction were expelled any time after the first maneuver, the remainder would be immediately discontinued. Let's see the Heimlich maneuvers again. Note that Marcia is precise where she places her hands. With her first hand, she locates the navel and holds the position, since the maneuvers will be given above the navel and below the notch at the bottom of the breastbone. Since the obstruction wasn't expelled by the time she had completed her 10th thrust, Marcia will return to the mouth and use the tongue-jaw lift to check for foreign objects. If it couldn't be seen to be removed, she would attempt to ventilate, using the head tilt chin lift to open the airway. Her index finger and thumb seal the nose, her mouth the victim's mouth. If the ventilation attempt is successful, no additional Heimlich maneuvers would be necessary. However, if the obstruction persists, Marcia would If Marcia discovered an adult were unresponsive to her questions, she would immediately shout for help.
Someone, I need help.
Then, making sure the victim was properly positioned, face up and arms at the sides, she would use the head tilt chin lift maneuver to open the airway and would check for breathing for 3 to 5 seconds. Her ear would be close to the victim's mouth, her eyes focused on the chest. Discovering the victim wasn't breathing, Marcia would seal the nose and mouth, maintaining the airway at the same time, and attempt to ventilate. If she encountered resistance, her first thought would be that perhaps she hadn't fully opened the airway. She would reposition the head and attempt a second ventilation. Note that her eyes remain focused on the chest. By this time, if someone had responded to her shout, Marcia would send them for emergency medical help. Since the second ventilation attempt proved unsuccessful, Marcia would know the victim had an obstructed airway and would immediately begin a series of up to 10 Heimlich maneuvers. These would be done exactly as those given to the obstructed airway victim who had become unconscious. Remember, the instant the foreign object is expelled, the Heimlich maneuvers should be stopped. If the abdominal thrusts were unsuccessful, Marcia would A conscious child with an obstructed airway receives the identical assistance a conscious choking adult would receive. Kathy will immediately do two important things: reassure Sarah and quickly assess the problem. A choking child in panic needs prompt reassurance.
Are you okay? Are you all right? I'm going to help you. Everything's going to be fine. Can you cough for me? Cough, honey. Cough. I need some help.
Since there has been no reaction from Sarah, Kathy realizes she needs her physical help more than her emotional appeal. She will begin a series of Heimlich maneuvers, but for the benefit of the viewers, will do the sequence slowly. She positions herself behind Sarah and wraps her arms around her waist. She then locates her navel with the fingers of one hand, holding the position. She then makes a fist with her other hand, tucking the thumb inside, and places the thumb side of the fist against the abdomen, above her fingers, but below the notch at the base of the breastbone. The hand whose fingers were on the navel now goes around the fist. Kathy is now ready to do as many Heimlich maneuvers as necessary to expel the obstruction or until Sarah would lose consciousness. Note that the maneuvers are given forcefully in an inward-upward motion. Again, the rescuer should never attempt to put a finger into a conscious victim's mouth. If the conscious victim lapses into unconsciousness, the rescuer should aid him or her to the floor or ground. The conscious obstructed airway child who becomes unconscious immediately presents a new trauma for the rescuer. If no one had responded to the initial shout for help, the rescuer should call out again.
Help someone. I need some help.
Since the child has been properly positioned, Kathy will now use the tongue-jaw lift to check the interior of the mouth. If the foreign object could be seen, it would be removed, being plucked out or swept out. If it weren't visible, Kathy would immediately open the airway with the head tilt chin lift maneuver. She would then attempt to ventilate after sealing the nostrils with the index finger and thumb of her upper hand and the mouth with her mouth. If there were resistance to her breathing effort, Kathy would immediately know it and would move to the child's thighs, straddle the legs, and begin a series of up to 10 Heimlich maneuvers. Note how the proper location is found, the fingers locating the navel, the heel of the opposite hand going on the abdomen, and then the placement of the hand going on top of the hand on the abdomen. The rescuer's arms should be straight so that the abdominal thrusts are given in an inward-upward motion. If the obstruction were expelled any time before the 10th maneuver, no further thrusts would be given. However, if there were no relief after the 10th maneuver, the rescuer would return to the head, use the tongue-jaw lift to peer into the mouth,
remove the obstruction if visible. If not, open the airway and attempt to ventilate. And if there were resistance, she would begin another series of up to 10 Heimlich maneuvers. The sequence would be continued until the foreign object was expelled or emergency medical help arrived. Unlike the child who has an obstructed airway and becomes unconscious, the child discovered unconscious is an enigma. The rescuer will only become aware of the obstruction after a number of basic life support efforts. Kathy, coming on the victim, will first determine unresponsiveness. She shakes the child by the shoulders and asks,
Are you okay? Are you okay? Can you hear me?
Failing to get a response, Kathy will shout for help.
Help, someone, I need some help.
She will now open the airway with the head tilt, chin lift maneuver, her upper hand pushing the head back, the fingers of her lower hand lifting the chin. Note, the fingers are not on the soft tissue of the neck. Maintaining the airway, she checks for breathing for 3 to 5 seconds. Since the victim is without spontaneous breathing, Kathy will attempt to ventilate, first sealing the nostrils and mouth of the victim. However, she encounters resistance, but believing that perhaps she hadn't fully opened the airway, repositions the head and attempts a second ventilation. When this is unsuccessful, Kathy knows the victim has an obstructed airway. She will immediately do up to 10 Heimlich maneuvers. If these prove unsuccessful, she will return to the head and use the tongue-jaw lift to peer into the mouth for the foreign object. If the obstruction can't be seen, she will then attempt to ventilate. If there is continued resistance, Kathy will then do
If 8th grader Jennifer Edwards were babysitting and the infant suddenly began having some breathing difficulties because of an airway obstruction, it's very likely she would know what to do to relieve the obstruction because of having passed the basic rescuer course of the American Heart Association. First, she would determine the seriousness of the problem. Even though the infant might be wheezing, if the lips remain pink, the rescuer should take no physical action except to monitor the baby. This monitoring would take far less than a minute because the infant would either resolve the problem on its own or would require basic life support. Even though a babysitter would very possibly have the phone number where the parents could be reached, contacting them would not be Jennifer's first priority. If she believed the situation were serious enough, and with the infant in her arms, she would immediately phone 911 or a 7-digit emergency number that should be displayed on or next to the phone. Babysitters should never hesitate in phoning for help. Even though she knows she is alone in the house, Jennifer shouts for help. In times of emergency or suspected emergency, babysitters should always shout for help. If the infant's breathing quickly disintegrated, then Jennifer would begin her life-saving efforts. The infant's obstruction would be critical if the face, fingernails, and lips began turning blue. The attempts at spontaneous breathing might also disintegrate, but the change in color would be undisputed evidence the infant had a complete airway obstruction. Jennifer immediately places the infant face down along the length of her arm, the head lower than the trunk. Note how her hand protects the head and neck from moving. This is vital. Jennifer now places her arm on her thigh, giving the infant additional support. The arm and thigh should be on the same side of the rescuer's body. She now delivers 4 back blows, forcefully between the shoulder blades with the heel of the opposite hand. Repeating, the heel of the hand is used. She now gently grasps the back of the infant's head and turns the baby face up on her arm, the entire body on the arm, and the head again lower than the trunk. Jennifer now delivers 4 chest thrusts with the tips of 2 fingers on the midsection of the breastbone. The thrusts are given forcefully in 3 to 5 seconds. Note Jennifer's fingers are vertical on the breastbone, not horizontal. If the obstruction hasn't been expelled by the time the 4th chest thrust has been made, Jennifer will do 4 more back blows, then 4 more chest thrusts, repeating these sequences until the foreign body has been relieved or the infant loses consciousness. 3 strong warnings. Never reach into a conscious infant's mouth in an attempt to remove the foreign body. Never push on or into an infant's stomach, conscious or unconscious. There are no exceptions to this precaution. When holding an infant face down, be certain the fingers aren't wrapped around the throat. Jennifer's back blows and chest thrusts weren't successful, and the conscious infant became unconscious. Jennifer now has an option, but one that must be decided on quickly. She can continue keeping the infant on her arm, or place it on a firm surface. She decides on a nearby firm surface. This is a wise decision. An adult might easier hold the infant, but since she herself is still a child, Jennifer believes she might waste valuable time trying to properly maintain the infant's position. She will now check the inside of the mouth for the foreign object, using the tongue-jaw lift. She places her thumb over the tongue and her fingers around the lower jaw, on the jawbone itself, and lifts up. This maneuver exposes the interior of the mouth and allows Jennifer an unrestricted view. If Jennifer were able to see the obstruction, she would pluck it out with 2 fingers or sweep it with 1 finger to the front of the inside of the mouth, where it might be removed. However, she saw nothing and will use the head tilt chin lift maneuver to open the airway. Note that the fingers of her lower hand are under the chin and on the jawbone, not on the soft tissue of the neck. Jennifer attempts to ventilate, but encounters resistance from the obstruction. Quickly now, she removes the infant from the firm surface and does 4 back blows, followed by 4 chest thrusts. Each 4 maneuvers would take 3 to 5 seconds. If the obstruction hadn't been expelled during the back blows and chest thrusts, Jennifer would open the mouth with the tongue-jaw lift, check for the obstruction, and remove it if possible. If it weren't visible, she would open the airway, seal the nose and mouth, and attempt to ventilate. These efforts would be continued until the obstruction was expelled or emergency medical assistance arrived. If Jennifer, babysitting, discovered the infant unresponsive to her attempts to rouse it, she would immediately shout for help, and then, as Janet did in giving infant CPR, place the baby on its back on a firm surface, open the airway, and check for breathing for 3 to 5 seconds. Discovering the infant is breathless, Jennifer seals the nose and mouth with her mouth and attempts to ventilate. Since she encounters resistance, she repositions the head and attempts to ventilate a second time. She would attempt the second ventilation because she might think she hadn't opened the airway fully. However, encountering more airway resistance, she would now positively know the baby had an obstructed airway. She would do 4 back blows. And then, knowing the foreign object hadn't been expelled, 4 chest thrusts. She would then open the baby's mouth with the tongue-jaw lift, and if she saw the obstruction and could remove it without complicating the problem further, she would. If nothing were visible, she would. This cycle would be continued until help arrived or the obstruction were removed. You have just viewed an authoritative CPR teaching presentation, but as thorough as CPR The Way to Save Lives is, it should not be considered a replacement for hands-on training under the supervision of a certified CPR instructor. Those interested in class information should check with the American Heart Association, American Red Cross, local schools, hospitals, police departments, and fire departments. Canadians should take classroom instruction when possible.